Next, we move on to the long case presentation by Dr. Abhinav and Dr. Vaishnavi on the topic ischemic heart disease patient for non-cardiac surgery. The internal examiner for this case will be Dr. Baburaj, Professor and HOD of Government Medical College, Trichur. The external examiner is Dr. Suvarna K, Professor at Government Medical College, Manjeri. Let's proceed with the presentation.
Good morning, all. See, we Keralites are very proud that we are number one in many aspects compared with other parts of India. And we are also number one regarding the prevalence of coronary artery disease. A study which was conducted in 2016, a cross-section study in the South India, they found that the prevalence of CAD in males and females was respectively 6% and 3% respectively, which is almost similar to that in USA and UK. So that means every anesthesiologist has to provide anesthesia every day to a patient with CAD, and moreover for postgraduates, it's a definite question in practical as well for theory. So let us move on to the discussion. Ischemic heart disease patient coming for non-cardiac surgery. We have Dr. Abhinav, AIJ, and Vaishnavi with us. You can present the case.
Good morning, all. The case is ischemic heart disease patient for a non-cardiac surgery. The patient name is Miss A, age is 55 years, female, and she is a housewife. The chief complaints are the patient has abdominal pain for 1 week and vomiting for 5 days. History of presenting complaint, the patient was apparently normal until 1 week when she started to have abdominal pain in the right side, which was colicky in nature and was intermittent with no radiation. There was associated nausea and multiple episodes of vomiting. The vomiters contained partially digested food particles. There is no history of fever, jaundice, constipation, loss of weight, or appetite. There is no history of chest pain, dyspnea on exertion, orthopnea, and PND. There is no history of palpitation and syncope. There is no history of recent URTA or LRTA. The patient is able to climb more than 1 flight of stairs. Past history, it is a non-case of ischemic heart disease for 1 year, and there is history of anterior wall MI 1 year back, and she underwent PTCA to LAD using drug-eluting stent. There is no history of diabetes mellitus, bronchial asthma, hypertension, pulmonary TB, cerebrovascular accident, or epilepsy. Treatment, the patient is on tab aspirin 75 mg OD, tab clopidogrel 75 mg OD, tab metoprolol 25 mg OD, tab pantoprazole 40 mg OD, tab sorbitrate 5 mg SOS. The family history, there is no similar complaints in the family. There is no history of any congenital heart disease or sudden death in the family. Personal history, mixed diet, appetite is normal, sleep is normal, bowel and bladder habits are normal, is non-smoker and non-alcoholic. Menstrual history, she has attained menopause 8 years back, and her obstetric history is she is P3, L3, full-term normal delivery, and it was uneventful. Summary, she is a 55-year-old female with complaints of abdominal pain and vomiting 1 week back with history of ischemic heart disease 1 year and underwent PTCA, and is on tab aspirin and clopidogrel.
Regarding the general physical examination, patient is moderately built and nourished, conscious and oriented to time, place and person, weight 60 kg, height 158 cm with BMI of 24. Patient has no pallor, icterus, cyanosis, clubbing, lymphadenopathy or edema. Vitals, heart rate 64 beats per minute, regular, good volume with no radiofemoral delay. All peripheral pulses are felt well, and the BP is 130 by 80 millimeters of mercury measured in the right arm in sitting position. Respiratory rate is 14 per minute, thoraco-abdominal type. Systemic examination.
Any positive findings in other systems?
Only the Murphy's sign was positive in the abdominal examination. All other
any other okay, except for Murphy's sign, there are no other
positive.
Okay. In the cardio system, anything else?
No.
Respiratory system?
No.
Nothing. CNS, nothing. Okay. Okay.
Airway examination.
Okay, stop. You can stop there. So in the history, you was mentioning negative points like no history of dyspnea, palpitation, etc., etc. So what's the relevance of asking about, or what are the special things you ask in the history especially in a patient who had a CAD and having a stent, other than routine things?
While the patient comes for evaluation, we should ask for the history of ongoing anginal pain, and we should also ask the history related to heart failure, like history of dyspnea on exertion, orthopnea, paroxysmal nocturnal dyspnea, and peripheral edema or any abdominal pain. And we should also ask the history to assess the functional capacity of the patient.
Okay, so how do you assess the functional capacity? How much is in your patient?
If the patient can climb a flight of stairs, functional capacity can be measured using METs, that is metabolic equivalent of task. One METs is the oxygen consumption of a person at rest. It is equal to 3.5 ml of O2 per kg per minute. So METs, it is the assessment. We can assess the functional status using METs, or another method is Duke's Activity Status Index. It is a validated questionnaire. It constituted with 12 questions, and it has a scoring from 0 to 58. And if the patient is having a score of less than 34, he or she is considered to have a poor functional status.
Okay, so whether METs or Dukes, which will you prefer?
METs is a subjective measurement, whereas Duke's Activity Status Index is a objective measurement. We can calculate METs from Duke's Activity Status Index.
How do you?
It is calculated using a formula, that is 0.43 into Duke's score plus 9.6 divided by 3.5. We'll be getting the METs.
So how much METs in your patient?
Here the patient can climb more than 2 flights of stairs, so he's having more than 4. So which is considered good.
So in the examination, you mentioned about airway examination. What is the importance of, pertaining to or concentrating on airway examination on this patient with CAD compared with, other normal patients?
As the patient is having ischemic heart disease, we should anticipate a difficult airway. If the patient is having any difficult airway, so we should plan accordingly so that the stress response can be decreased, so the myocardial oxygen supply and balance can be adequately met. So preventing MI.
If it is a difficult airway, whether it is a difficulty for ventilation or intubation, there is every chance of triggering stress response. Okay, and you are worried about oxygen demand supply balance. What do you mean by that? Oxygen demand supply balance.
We should maintain the oxygen supply, and we should decrease the myocardial oxygen demand to maintain the coronary perfusion, and thus thereby we can reduce the risk of perioperative MI. To maintain
So what are the factors which affect the oxygen demand, and what are the factors which affect oxygen supply?
Oxygen demand is mainly dependent on the contractility, the afterload, the preload, and the heart rate, whereas the oxygen supply is entirely dependent on the coronary perfusion pressure and on the coronary blood flow, the diameter of the coronary vessels, then also the oxygen carrying capacity of the blood, hemoglobin, anemia.
Just enumerate, because every anesthetist should have these factors in mind. Whenever they are inducing throughout the perioperative period, they should have these factors in mind. Can you just enumerate?
The coronary oxygen supply is mainly dependent on the coronary blood flow. So the oxygen carrying capacity is mainly dependent on the hemoglobin. So we should check whether the patient is having any anemia. Then the tachycardia as such can cause decrease in myocardial oxygen supply, as the coronary perfusion pressure is entirely dependent on the diastolic time, whereas in tachycardia, the diastolic period is decreased. So we should address.
Tachycardia can be considered as a double-edged sword, right? On one hand, it increases the contractility and increasing demand. On the other side, reduces the perfusion by reducing the diastolic. So at any cost, we have to prevent tachycardia. Fine. Then saturation also, because you mentioned about oxygen carrying, oxygen content, right? So the two factors which are variable are hemoglobin and saturation. So you have to maintain saturation, you have to prevent hypoxia. Okay.
What is this oxygen content?
Oxygen.
Oxygen content of the blood is dependent on both the dissolved oxygen as well as the hemoglobin carrying oxygen. So it is calculated with the formula 1.34 into hemoglobin into oxygen saturation plus 0.003 into PO2.
Okay. So there comes the importance of hemoglobin assessment and optimization preoperatively. So you can increase the oxygen content. So you said you complete the factors affecting the supply.
Coronary blood flow, hemoglobin content, oxygen content of the blood,
Tachycardia.
heart rate.
And what about the coronary diameter? Coronary diameter. You know, it is a non. This is something which cannot vary because it's already there. But there is something. There is another factor which can reduce coronary diameter, which you can manage. What is it? Something connected with your ABG.
Hyper.
Carbon dioxide. Hypocarbia is a vasoconstrictor. Coronary constrictor, right?
So our anesthetic goal should be maintaining this oxygen supply demand balance. So that is the most important in a CAD patient. So we should be remembering these factors which affect the supply and demand. So please tell them how the coronary circulation is different from the systemic and how it is actually.
Coronary circulation is mainly entirely dependent on the diastolic period, whereas systemic circulation on systolic. Then this coronary circulation, we mainly depend on the coronary perfusion pressure. The coronary perfusion pressure is aortic diastolic pressure minus the left ventricular end diastolic pressure. And this gradient, it is mainly dependent on the coronary perfusion pressure gradient. Once the gradient decreases, that is during systolic time, the gradient decreases, so the perfusion doesn't take place. So it is mainly happening in the left ventricular side, whereas on the right ventricle, there is no much wall thickness. So the end diastolic pressure is not much affected, so the gradient is not affected. So it is mainly the left ventricle that is affected, whereas the right ventricle remains almost both systolic and diastolic. The perfusion is taking place both in the systolic and diastolic time, but in the left ventricle it is mainly affected during the systolic.
So you should maintain the coronary perfusion pressure, and this pressure difference is mainly in the diastole in case of left ventricle because it is a thicker muscle mass. So during systole it compresses the coronary vessels, whereas in the right side this phasic changes is not there.
Okay, in the history you mentioned about many drugs. Okay, what is the anesthetic concern? What are the anesthetic concerned about these drugs?
Here this patient is on antiplatelet drugs, so this patient is on tablet aspirin. It should be continued on the day of surgery, and the patient is also on tablet clopidogrel. It has to be stopped 5 to 7.
Why are they put on this dual antiplatelet therapy?
The patient has undergone PCI, so there is a stent in situ of the patient. So the antiplatelet therapy is it is necessary to prevent stent thrombosis. Stent thrombosis is a major concern why we are proceeding with dual antiplatelet therapy.
That means every anesthetist should be having some awareness about the stents. Okay, because many patients come for surgery with stents. So can you say something about the different type of stents and the advantage of this particular DES?
There are two types of stents, bare metal stent and the drug-eluting stent. Bare metal stents are they are made up of stainless steel, and these if a patient is on bare metal stent, and the patient can be posted for surgery after 30 days of stent placement. Drug-eluting stent, in the older generation, drug-eluting stents were made having sirolimus as a drug and paclitaxel as a drug. The latest generation drug-eluting stents have everolimus and jotarolimuz as a drug, and they are made up of cobalt chrome or platinum chrome based drugs. And if the patient had a drug-eluting stent placement, elective surgery should be planned after 12 months of the stent placement. And if it is a time-sensitive surgery, surgery can be planned after 3 months of the drug-eluting stent placement. And if the patient has chronic coronary disease and planning for elective surgery, it can be that surgery can be planned after 6 months of the drug-eluting stent placement.
Normal bare metal stent is just made up of a steel wire mesh, whereas the drug-eluting stent it has got a coating of drug which is continuously secreting the drug, so it prevents the anti-proliferative action of the smooth muscles, which prevents the further aggregation. So hence it is responsible for preventing stent thrombosis.
So that means other than the anticoagulation, we should be worried about the stent thrombosis, because stent thrombosis is going to be fatal. Okay.
So these drug-eluting stents are first generation and second generation. As older is the first generation, then comes the second generation. Now even third generation, which are bioabsorbable. Because after some 4-6 weeks they get absorbed, so you don't need to go with a continuous antiplatelet therapy. That's also coming up. So you should be familiar with when to stop the antiplatelet, what are the risks, and when you can plan an elective surgery. That is very important. Everyone should know. So drug-eluting stent, the time period for an elective surgery is
12 months.
12 months if it is placed for an acute coronary ACS. If it is for a CCS, you can do with the 6 months also. If it is a time-sensitive surgery,
3 months.
3 months. So this time period you should be very thorough about.
What's the meaning of time-sensitive surgery?
Time-sensitive surgeries includes like onco surgeries. The surgery should be done at least within 3 months of after the diagnosis. In such cases, we should try to do the surgery after optimization as soon as.
Cannot delay like an purely elective surgery. It has to be done within a particular time span. That is okay.
So sometimes the examiner may ask what are the other, what is an urgent surgery, what is an emergency surgery.
Emergency surgeries, it can be a life-threatening or a limb-threatening surgery, and it has to be done within 2 hours after.
Yes, that is with the latest 2024 AHA guideline, the time period has changed to 2 hours.
Urgent surgery, the surgery has to be done within 24 hours. So then in time-sensitive surgery, we can wait up to 3 months.
Surgery can also be classified depending on the risk involved.
It can be classified into high-risk surgeries, intermediate-risk surgeries, and low-risk surgeries. High-risk surgeries mainly includes vascular surgeries, cardiothoracic surgeries, aortic repair, and all. Then intermediate-risk surgeries include intraperitoneal repairs, head and neck surgeries, then lower prostate surgeries. Then low-risk surgeries include mainly breast surgeries, then ophthalmic surgeries, then endoscopy, colonoscopy, etc.
This particular patient.
The patient is undergoing a laparoscopic cholecystectomy, which is an intra-abdominal surgery, so intraperitoneal opening, so it is coming under intermediate risk.
Okay, so here this slide shows you a lot of a battery of tests, isn't it? What is the relevance of each?
Hemoglobin, we should evaluate whether the patient is having anemia. If the patient is having anemia, the patient is more prone to develop
Transfusion trigger for a CAD?
HP around 8 mg.
According to the guidelines, it is 8.
According to the latest guidelines.
But again, that depends upon the type of surgery. If you expect more bleeding, of course you can have a higher trigger also. Okay, for this patient, 8 is enough because there is not much bleeding you expect. Okay, then.
Platelet count, as this patient is on dual antiplatelet therapy, platelet count should be evaluated before the surgery. And regarding PTIN or APTT, we should know the coagulation profile before taking up for the surgery. And
blood sugar?
Here this patient's blood sugar is okay. If the patient is fine to have diabetes mellitus, patient is more prone to develop silent MI, or patient might be having any end organ damage that should be evaluated, and they might carry high risk for perioperative MI.
Electrolytes?
If the patient is having dyselectrolytemia, patient is more prone to develop perioperative MI during
this patient is liable for any electrolyte imbalances. The patient is on a beta blocker. Beta blocker can read on to what? Beta blocker. Hyperkalemia. Beta agonist, hyperkalemia, and beta blockers. So that is something we have to look for. Then ECG?
We should take a 12-lead ECG, especially for the patients with reduced functional capacity or a recent history of MI. With the new onset of dyspnea or symptoms of heart failure, ECG is all recommended. But with a patient with good functional capacity and no or a low risk for perioperative MI, ECG is not always recommended.
So even though guidelines say that there is no need for an ECG if the function set is good and risk is less, but routinely, since most of our patients are not undergoing, routine medical tests, as in other areas, other countries, I think it is safe to have ECG for every patient with CAD, even though guidelines say like that. Okay. Chest X-ray?
As this patient is a known case of ischemic heart disease, we should look for cardiomegaly, and if the patient is having heart failure, patient might be having some signs of pulmonary edema in the chest X-ray, so we should always look for it.
Echo is indicated in those patients who are having a poor functional status and who are having a new onset of dyspnea, then who is undergoing high-risk surgery. Echo is recommended.
So do you want further evaluation of this patient, further testing of this case?
For this patient, it is not necessary. As the patient is undergoing an intermediate risk surgery, and we can look further into the myocardial function using other invasive, non-invasive tests such as stress test can be conducted in these patients. The stress tests include non-invasive and invasive stress tests. Then non-invasive include stress ECG, stress echocardiography. Then cardiopulmonary exercise test is now recommended. It is normally conducted, the patient is, it includes treadmill test. The patient is provided with an activity and we are assessing the presence of cardiopulmonary reserve is assessed. Then
Also, SpO2 is monitored. Normal TMT, we are not monitoring the SpO2, but this particular cardiopulmonary stress we are monitoring. But for this patient, may not be indicated, but if indicated, it has to be done. Okay, then.
So what are the scoring systems used in a CAD patient?
for risk stratification, we can use the least revised cardiac risk index. It is normally used. It includes 6 components.
How much is the RCRI for your patient?
Here the patient RCRI.
What are the factors in RCRI?
Presence of ischemic heart disease,
Yes, that's
presence
one
of
point.
cerebrovascular accidents, disease, presence of congestive cardiac failure, then the presence of diabetes with on insulin, then serum creatinine level more than 2 milligram per deciliter. The patient if undergoing an intra-abdominal surgery.
For every case with a CAD, you have to calculate RCRI. So for your patient, it will come around only 1 point. And other risk scoring system?
National Surgical Quality Improvement Program is now recommended.
Yes, NSQIP. That also you can calculate. Actually, you can calculate the NSQIP online. And there is a app called MD Calc. You can download freely from the Play Store. So you can calculate many of the scoring, including RCRI, the Duke's activities. Many scoring systems are there. All these you can calculate with the MD Calc if you can download it. It's very easy. So what is NSQIP?
National Surgical Quality Improvement Program.
Okay. Okay, so your patient is scheduled for a laparoscopic cholecystectomy. So you have evaluated the patient. What preoperative advice the patient is on some drugs, patient is having so much functional capacity. So what all advice you are going to give?
If the patient is on beta blockers, we should ask
If the patient is, don't say, your patient is already on beta
as
blocker.
this patient is on beta blockers, we should ask them to continue the beta blockers. Statins should be continued, aspirin can be continued, and a clopidogrel should be stopped 5 to 7 days before the surgery.
Why do you want to continue beta blockers?
Beta blocker helps to maintain the myocardial oxygen supply, and it decreases the oxygen demand, and it also helps to prevent the tachycardia, and thereby it remains.
Mainly it prevents tachycardia and maintains the demand. Okay.
So what is the current recommendation regarding beta blocker? Suppose your patient was not on beta blocker. Will you start beta blocker?
If the patient is not on beta blockers and if the patient carries a high risk for perioperative MI, and beta blockers should be started as early as possible, at least 1 week before the surgery. If the patient is chronically on beta blockers, then beta blockers should be continued on the day of surgery. If the patient is not on beta blockers, we shouldn't recommend to start the beta blockers on the day of surgery.
If you are starting, you should start early as 1 week before, not on the day of the surgery. And what about other drugs with the patient you are having? You stopped clopidogrel. Since your patient is not only on these drugs, suppose many times these kind of patients will be having hypertension also. So they may be having other antihypertensive. Suppose the patient is on ARB or AC inhibitors. What advice you will give? Many patients you will come across with AC inhibitors or ARB.
If if the patient is on AC inhibitors or ARB, we should evaluate why that drug is started. If AC inhibitor or ARB is started for treatment of hypertension, then AC inhibitor or ARB can be stopped 24 hours before the surgery. But if it is given just for...
Why do you want to stop it? Why? What you are worried about?
AC inhibitors and ARB can cause a hypotension during the surgery time, and that might affect the cardiac.
And in which case?
Hypertension means you are worried about diastolic hypotension. So DBP minus LVDP is equal to CP. So you never allow the DBP to fall. With the continuation, it can happen. Okay.
So what is the controversy? Will you ever continue the AC inhibitors?
If the AC inhibitor or ARB is started for the patient with congestive cardiac failure with reduced ejection fraction, then we should continue the AC inhibitors or ARBs.
Yes. What about other calcium channel blockers and other antihypertensive?
Calcium channel blockers can be continued on the day of surgery. Antihypertensive agents has to be continued on the day of surgery.
Okay, you said you will stop the clopidogrel. Suppose it is a high risk case for there is high risk for thrombosis. what other precautions you can take?
We can continue with bridging therapy. Bridging means if you are using a long-acting antiplatelets, we can bridge it with a short-acting antiplatelet. Here, the patient is on a dual antiplatelet therapy. The patient is on aspirin and clopidogrel. So we can bridge it with a new onset, that is new agent, that is cangrelol can be used, IV cangrelol. It is a short-acting and it requires the stoppage of just 3 hours before the surgery. And we can restart it after 8 hours.
Okay, so if the patient carries a high risk for thrombosis, stent thrombosis, you can stop the long-acting drug before 1 week, 5 days before, and then bridge with a short-acting intravenous agent like a cangrelol. Okay.
How do you prepare this patient? Okay, patient, what is the ASA BS classification? Would you like to give 2 or 3 for this patient? 2, okay. Okay. What about preparation? You have assessed everything, and day before surgery, how do you prepare?
Preparation of the patient includes creating psychological as well as providing psychological as well as emotional support to the patient. We should provide information regarding the surgery as well as our anesthetic plan should be explained to the patient. This is for reducing his anxiety on the day of surgery. We can also provide anxiolytic agents can also be provided. That is, we should provide with IV tab.
Night sedation.
Night sedation.
What drug?
Alprazolam can be given, or lorazepam can be given. Then
Alprazolam, how much? 0.25 to 0.5, and lorazepam can be 1 milligram is sufficient for the most of the patients. Okay.
Then regarding NPO, we should also provide information regarding NPO. The patient should be having an NPO of at least 8 hours on solid foods and 6 hours on semi-solid. Clear liquids 2 hours. Then
what are the drugs which you are planning to give on the day of surgery at 6 a.m. with, let's say, half glass of clear water? What are the drugs for this particular patient?
Aspirin has to be continued. Metoprolol and statin can be continued. And for the pre-medication, we can ask him to take a tablet metoclopramide 10 mg per oral and a tablet pantoprazole 40 mg per oral.
And I may even give a small dose of anxiolytic also, because I don't want the patient to develop tachycardia because of anxiety. Okay. Regarding the psychological rapport, it is something which is essential, because Miller says psychological rapport is much more effective than milligrams of benzodiazepines. So you can't omit it. Okay.
So your patient is posted for laparoscopic cholecystectomy. Your patient is you adequately advised. You have made a rapport. Now on the day of the surgery, what anesthetic plan?
For this patient, we will go with the general.
A complete sentence, okay? Not piecemeal, complete.
For this patient, we will plan for general anesthesia with controlled ventilation with cuffed oral ET tube along with the thoracic epidural.
Okay. So what is your concern with the thoracic epidural? Why you are placing an epidural in this?
as this patient is a known case of ischemic heart disease, the placement of thoracic epidural, we can reduce the coronary, it can provide coronary vasodilatation, and coronary perfusion can thus be improved. Then sympathetic stress response can be decreased using thoracic epidural.
Excellent analgesia can be maintained intraoperatively and postoperatively. Hemodynamic stability can be maintained, and the overall anesthetic drug requirement can be reduced.
I agree that you require excellent analgesia, and there are several advantages for thoracic epidural. But since it is a laparoscopic cholecystectomy and your institutional practice is epidural, but some examiners may say, why don't you go for other alternatives, were simple because it is only a lab surgery. So what other alternative analgesic you can plan?
Can also provide tap block can be given, and along with spinal anesthesia can also perform.
Okay, TAP doesn't cause any hemodynamic instability. Okay, thoracic epidurals can cause some amount of sympathetic blockade. Okay. So regarding, I want to emphasize on certain important points. How do you put the cannula?
If the patient is very anxious,
Patient is anxious. She is going to be anxious. You are planning to put an 18 gauge cannula, right? How do you put it?
we will explain the patient, and then we can use a small dose of IV preservative-free
Okay.
lignocaine.
Local.
Local
Okay,
for
I want you to give local before you cannulate. Okay, right. Then, regarding pre-oxygenation, is it mandatory because you're worried about hypoxia? Okay. Regarding the induction agent, what is your induction agent of choice?
I will be using etomidate as an induction agent because it is cardiostable and it also The hemodynamic stability is also controlled with etomidate. You can also use titrated doses of propofol can also be used. I will be using etomidate.
Okay.
So what is the problem with the propofol? It's not mandatory that you will require etomidate for all cases. You can also go for propofol. But what are the problems with the propofol?
It can cause hypotension, and it may also cause bradycardia if we give very fast. So if we are using propofol, we should give a small titrated doses, and we should give according to the hemodynamics also.
Always go according to the hemodynamic response. You can go slow induction. Always whatever drug you are giving in a CAD patient, go for a slow titrated doses. Okay.
So you have a plan of anesthesia, and now the patient is on table, and what are the monitors you would like to have?
Pre-induction, we will be connecting pulse oximeter, 5-lead ECG with the ST analysis, and capnography, non-invasive BP monitoring, invasive BP monitoring. As this patient is
Would you like to put IBP for this patient?
Yes.
Pre-induction?
Yes.
Using local anesthetic, we can put invasive BP monitor.
So even a subtle changes in the BP, high increasing or decreasing can be, detected at once, and you can act at once. There is an advantage, okay? But some centers do not put IBP routinely, okay?
But in your case, IBP has another advantage because it's a lap surgery. Is there any other advantage other than monitoring the BP?
As this patient is undergoing lap surgery, she is more prone to develop hypercarbia, and as we are having IBP, we can do ABG analysis and correct hypercarbia earlier.
Okay, so invasive BP monitoring is not a must for this lap surgery, but it has an added advantage of noting the ABG analysis, taking samples. Okay.
Muscle laxant of choice for this patient?
Vecuronium.
Vecuronium, okay. Before laryngoscopy and intubation, would you like to blunt the response, sympathetic stimulation responses? How do you do that?
Yes, sir. We should deepen, we should give titrated doses of induction agent, and if needed, we can give additional titrated doses. We can use IV preservative-free lignocaine 1.5 mg per kg, and we can use esmolol. Opioids can be given. Inhalation agents can also be used if needed.
And more important is a short and gentle laryngoscopy. You do maintain adequate depth as well as suppress the stress response with the pharmacological agent. More important is doing a short, gentle laryngoscopy. Okay.
And once you do the laryngoscopy, you can even spray vocal cords. Okay. So that will provide excellent, suppression of severe responses when you put the tube also. Okay.
So whatever method, you should suppress the intubation stress response because that is going to affect the oxygen supply demand. So how do you maintain?
As this patient is undergoing laparoscopic surgery, we will be using oxygen with the air, and as this patient is already having thoracic epidural, we can have an epidural infusion, and then we can use a muscle relaxant vecuronium, and opioid fentanyl can be used as it is a short procedure.
So what airway equipment you have selected? Endotracheal tube.
Endotracheal tube.
So what other option or what are the problems within endotracheal tube in this case?
There is a definite airway securing with the endotracheal tube. We can also use a supraglottic airway if it is a short procedure. Second generation supraglottic airways can be used, which can prevent aspiration.
Yeah, second generation supraglottic airway device also can be used safely in lap surgery also. There are several reports because its stress response, the intubation stress response, as well as the smooth recovery also, especially in this case with the CAD. So, but there are definitely the standard technique is endotracheal intubation, cuffed intubation.
Okay, do you expect hypotension after induction while surgeon is positioning the patient?
Yes, sir.
What are the reasons for hypotension?
Due to the drugs that we give during.
Okay, because during before laryngoscopy and intubation, you are using many drugs. Okay, blunting everything, and there might have been hypertensive response which you treated with additional doses, and there is a period during there is no stimulation, isn't it? So that can cause hypotension. Okay, because of the effects of the drugs you have given. Okay, that is number one. Number two.
And as it is a laparoscopic surgery, the positioning of the patient with the head up with the lateral tilt will decrease the venous return, and that might also affect the that might also cause hypotension and creating a pneumoperitoneum for a laparoscopy.
Okay, after 6 minutes, you see BP is 70. It was pre-op, it was 120. there was a slight rise of 140, now it is 70. How do you manage?
You can provide IV fluids can be given. IV fluids is given, then phenylephrine vasopressor is used.
Vasopressor?
Phenylephrine is the drug of choice. Then initially IV fluids, then if it is not resolving, then we'll go for vasopressors.
So, intraoperatively, what are the complications you expect? Because this is a CAD patient with a stent with good function. Still, you have to anticipate many things. Which are they?
There is chance for hypertension, hypotension, then tachycardia, bradycardia, then perioperative MI can occur.
Some of the thing which is happening usually, even in a normal patient, which worries you a lot.
Arrhythmias.
Ectopics, isn't it? Atrial ectopics, ventricular ectopics. You're worried about ventricular ectopics, and if you see, a lot of ventricular ectopics coming, how do you proceed?
We should look for the morphology of the ventricular ectopic. If it is more than 3 on a running, or if it is more than 6 per minute, or if it is having R&T phenomenon, then we should try to evaluate the cause of the ventricular ectopic. We should look for whether the patient is having hypoxia, hypercarbia, or any electrolyte imbalance that should be treated. And we can give IV lignocaine or NTG or beta blockers can be used if needed.
So you said no hypotension you will correct. So you should try to maintain the hemodynamics when, within 20%. You should never allow the fall more than 20% above or below. Always try to maintain the mean arterial pressure above 60 or 65 and never allow the systolic BP to fall less than 20% from the baseline. So once the surgery is over, how are you planning your reversal and extubation?
Reversal can be made with neostigmine along with glycopyrrolate. Then extubation is it is done when the patient is fully awake. This is to reduce the risk of aspiration. Once the patient is fully awake, he can himself control the airway. So there is risk of aspiration is decreased.
And the stress response during extubation has to be reduced. Before extubation, we can give IV preservative-free lignocaine, and we should extubate in a very smooth manner and very fast.
See, there are two options. Here, we are worried about surgery response. One is extubation in deep plane or extubation when the patient is fully awake. So you would like to extubate when the patient is fully awake. What's the problem of extubation in a deep plane, especially in this particular patient who is undergoing laparoscopy? I gave the clue also.
Chance for hypercarbia and hypoxia may be present, so it can affect the patient. It can result in aspiration also. Then
aspiration is an issue. Then hypoxia. If the patient hypoventilation, you are very much worried about oxygen supply, and you are worried about the hypercarbia which can happen secondary to your pneumoperitoneum. Okay.
How is the postoperative management?
Postoperatively, we should give adequate analgesia. As this patient is having epidural, we can go with epidural infusion. Even IV analgesics can be used, opioids can be used if needed. And we should maintain normothermia, we should avoid hypothermia, oxygen supplementation should be given, and we should monitor the ventilation.
You said specifically hypothermia. What is its significance?
Hypothermia itself.
Intraoperatively also you are worried about hypothermia, isn't it? What is its significance?
Hypothermia itself is a myocardial depressant, and if the patient is having hypothermia, they will develop shivering, which will increase the oxygen consumption, and hypothermia will also increase the
shivering in the postoperative. Nobody is going to shiver.
And
myocardial oxygen demand increases while shivering, and hence can affect the oxygen supply demand.
So that means pain management is the most important thing in the postoperative, because any type of pain, patient will be having nociceptive, somatic, visceral, everything is there. Visceral is of course less because it is a keyhole surgery. But any type of pain is going to increase the sympathetic stimulation and initiate a ischemia or infarction.
Suppose in the postoperative period, the nurse call you and say the patient's BP is falling and he's complaining of some chest discomfort. How will you proceed?
Initially, we should take a 12-lead ECG. Then cardio biomarkers can be sent for investigation. Then there is the most common chances the perioperative MI, postoperative
biomarker,
period.
which biomarker?
Cardiac troponin I is the most
sensitivity.
high sensitivity body. Then postoperatively MI can occur within 72 hours post surgery. So
In
first-
which period the perioperative MI is most common, intra-op or post-op, and why?
Post-op period within 72 hours of surgery. Mainly due to adequate analgesia is the most concern. If the patient is not having adequate analgesia, he can go for stress response and induced tachycardia causing imbalance in myocardial oxygen supply.
Okay. Then how do you manage? Suppose the biomarkers are elevated.
You should consider it to be a perioperative MI and should provide with coronary vasodilators can be given, if given, like nitroglycerin is used.
First, do a multidisciplinary discussion, cardiology evaluation, and plan accordingly, because you have to balance the bleeding risk also. Okay. So I would like to ask Gurudat sir and senior other members to contribute. Ramkumar sir. Sir, please contribute to the topic. No. Any controversial points? Actually, I'm very proud to sit here with my own teacher and my examiner, Ramkumar sir, and with students. I'm very happy that this. And thank the organizers for inviting us. And thank you, both of you presented well.
Thank you.
Thank you.
Thank you, doctors. Now, I request Dr. Suvarna to kindly distribute the participation certificates to Dr. Abhinav and Dr. Vaishnavi. May I now request Dr. Radha KR to kindly come onto the stage to felicitate Dr. Baburaj. I also invite Dr. PMA Bashir onto the stage to kindly facilitate Dr. Suvarna.